Hello. On behalf of Mahiyanganaya Clinical Society, I would like to welcome you all to the 9th session of our academic program for continuous professional development. The lecture series is organized by the Clinical Society of BH Mahiyanganaya in collaboration with the Government Medical Officers Union of Mahiyanganaya. So far, we have had so many fruitful and successful sessions, all thanks to your active participation and commitment. Today, we have the opportunity to broaden our horizon on one of the pivotal topics, and septic shock, a subject that transcends to all the fields of clinical medicine, no matter what your specialty is. We are honored to have with us Dr. Sumudu Senavirathne, the consultant anesthetist of BH Mahiyanganaya, who will be sharing her expertise with us today. So without further delay, I introduce Dr. Rohit Amarvithana to formally invite our speaker. So this podium is yours.
Good afternoon, everybody, and you all are welcome to the academic session GMOA Mahiyanganaya Hospital. My duty is to introduce today's speaker today, Dr. Sumudu Senavirathne, consultant anesthetist, based hospital Mahiyanganaya. Dr. Sumudu Senavirathne, MBBS Peradeniya, MD Anesthesiology Colombo. She graduated from the University of Peradeniya 2021, Anesthesiology 2019 from the University of Colombo. She completed her overseas training at NHS Trust UK. After completing her overseas training, she worked as a consultant anesthetist at Sirimava Bandaranayaga Specialist Children's Hospital, Peradeniya from 2023 to 2024. She had excellent academic performance and she won distinction in surgery, AC Fernando Prize in surgery, and Rockwood Gold Medal for surgery in Final MBBS 2011. Also, she won Ponnambalam Prize and Gold Medal for the first place in the MD 1B exam 2016. Also, she won medal for the highest mark in Physics and Clinical MD Anesthesiology Part 2 exam 2019. Identification and management of sepsis and septic shock. Over to you, Dr. Sumudu.
Let me stop sharing then. Okay. There's a view that gives the name. So there we go. All right. So good afternoon, everyone, and thank you, Dr. Rohit, for this kind words of introduction. So as Malik said very correctly in his introduction for this lecture, sepsis is a topic that sort of relates to each and every one of us in any clinical specialty, and also it can affect any patient, any age group, and also it has a high mortality and morbidity if it's not identified early and if it's not treated properly. So it's like a very timely topic that we are discussing here today. And before we go on to the topic itself, how large a problem is sepsis? So in the Lancet, which is a renowned article, a renowned journal, in 2020, they have published this global sepsis burden study, where they have studied the global, regional, and national sepsis incidence and mortality for the year 2017. And they have found out that there's an estimated 48.9 million of cases of sepsis were recorded for the year 2017, and out of it, 11 million sepsis-related deaths were reported, representing 20% of all global deaths. So, for that year, about 1/5 of the global deaths were due to sepsis, which is quite significant. And in NCPOD, in November 2015, they have found out, according to their data, they have published that sepsis kills more people than breast, bowel, and prostate cancer combined in the UK. Probably even more than this, because a lot of cases go unreported. And in the USA, in 2011, they have accounted more than $20 billion was spent to manage sepsis and sepsis-related problems. And the UK Sepsis Trust, which is an organization which sort of does research on sepsis and sets up guidelines for sepsis, they have estimated around 245,000 cases of sepsis per year in the UK, out of which about 48,000 people die because of complications of sepsis, and about 80,000 patients has life-changing side effects because of sepsis. So it's, as I said, it's a very important topic, and also it's a global burden. So what about sepsis in Sri Lanka and in Asia? How large a problem is sepsis in Asia? Do we have data from Sri Lanka? As we all know, none of our sepsis cases that we encounter in the wards goes reported. We don't report each and every case of sepsis. Some infections we do report to the community medicine departments, but each and every cases related to sepsis does not get reported. So there's no published data available for Sri Lanka. But interestingly, in the BMJ, they have published an article, Management of Severe Sepsis in Patients Admitted to Asian Intensive Care Units. So they have, over a period of time, they have analyzed the data from 16 intensive care, from 16 different Asian countries, and over many intensive care units in those countries. And Sri Lanka is not amongst those 16, but they have found out that the hospital mortality from sepsis in the intensive care units came close to 50%. So 50% of the patients who were admitted to the intensive care unit succumbed to their illness. So it is indeed a big problem. So sepsis kills. So it's very important that we recognize sepsis and resuscitate or start treating those patients, and also refer appropriately. So is it difficult to diagnose sepsis? It could be, because sepsis can have a number of phases. In some cases, it will be very easy to identify. The patients will show classic signs of infection, inflammation. They will have fever. They will be showing, they will have increased markers of inflammation, increased white cell counts, and you will probably find a focus of infection as well. So it will be easy to identify. But in some cases, it might not be so obvious, and it frequently goes underdiagnosed. So early recognition of these patients, having screening programs, be vigilant about being vigilant about these patients in the ward will always help to identify them or recognize them early. So before we move on to the management, let's just clarify what is sepsis. So sepsis is defined from the third, there's a international organization called the Surviving Sepsis Campaign, which sets out these internationally accredited guidelines for the management of sepsis, which we will come on to discuss later in the lecture. So they have decided back in 2016 in their third annual consensus, they have come to a conclusion to define sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So there's an infection in the host, and as we all know, the host will mount an immune response to fight this infection, but this immune response goes uncoordinated, dysregulated, and that will result in life-threatening organ dysfunction. And also there's a subset of sepsis which they have defined as septic shock, which has very high mortality and also morbidity and mortality, which is a subset of sepsis with circulatory, cellular and metabolic abnormalities. So from sepsis the patient has moved on to septic shock, where now there is established multiple organ dysfunction. So we'll go a bit into the pathophysiology of sepsis. So I said when there's an infection, the host will mount an inflammatory or an immune response. So there's complex interaction between the pathogen and the host's immune system initial to fight this infection. So, this physiological response from the body to this infection activates host defense mechanisms, the immune system. So immune mediators in the body, when it goes unregulated, when it goes dysregulated, these immune mediators will dilate your vasculature, which can result in hypotension. So as we all know, blood pressure equals to the cardiac output into the systemic vascular resistance. So if your vessels are dilated, your systemic vascular resistance drops, and that in turn results in low blood pressure. What happens if there's low blood pressure? If you do not sort of address it, there will be a reduced perfusion of vital organs. Your brain will not get perfused properly, the heart, the liver, the kidneys, and all organs will, irrespective of where the infection is, all the organs will start failing or show signs of dysfunction. And also the immune system, the immune mediators can cause leaky capillaries. It can leak, the fluid will start, there will be increased permeability of the capillaries, and the intravascular fluid will start extravasating into the extravascular compartment, which will result in tissue edema, and also in turn, because it reduces the intravascular volume, it will worsen the hypovolemia and also the hypotension. And also the immune system, you know, your complement system, which is important in this, it's an important branch of your innate immunity. It can result in activation of the clotting cascade, and this will result in generation of microthrombi. These microthrombi can go and lodge in your microcirculation of the vital organs, and that also will result in organ dysfunction, and also it will ultimately result in a consumptive coagulopathy and a disseminated intravascular coagulation. So in sepsis and septic shock, the function of any vital organ, as I said, may be reduced regardless of the source of infection, whether it's a soft tissue infection, whether it's an infection in your lungs, in your brain. Regardless of the source, if the patient develops sepsis and this immune response becomes dysregulated, it can affect any of your organs. So it will be evident in the neurological system if the brain is not perfused properly. If there's hypotension, it will be evident as an altered mentation of the patient. Patient may be confused, low GCS, disoriented. And in the cardiovascular system, there'll be hypotension. Because of hypotension and hypoperfusion, the lactate levels will be going up. There's reduced clearance of lactate from the peripheries because there's reduced perfusion. The tissue will start anaerobic metabolism. There will be increased lactate production, and that will not get cleared because there's reduced perfusion. And also there will be ultimately like reduction of your myocardial activity as well. In the liver, it will show increased it can result in acute liver injury associated with sepsis, with your liver enzymes being high, your bilirubin levels going up, and the albumin levels going low, and also elevated coagulation abnormalities as well. In the renal system, the patient can become oliguric, rising renal functions. And in the respiratory system, so may it be a primary infection in the lungs like a pneumonia, or it could be a sepsis-related ARDS developing, which can result in hypoxemia, which will sort of further aggravate the tissue oxygenation in other parts of the body as well. And in the hematological system, due to this activation of the clotting cascade, there will be a consumptive coagulopathy and a disseminated secondary to a disseminated intravascular coagulation. So sepsis can result in multiple organ dysfunction, increasing the morbidity and the mortality of a patient. So before we go on to the management itself, I said we'll just look at the evolution of sepsis. So people have identified sepsis is an important thing, and they have sort of back in the 1992, they have first defined this term of sepsis. But then at that time, they thought if there's a presence of an infection, if there's the presence of an infection in a patient who shows signs of a systemic inflammatory response, they called it sepsis. And they have been making guidelines and making international guidelines and directing people how to manage this sepsis. And in the year of 2022, the Surviving Sepsis campaign was born. And again, they have reconvened many times. And as I said, in 2016, they've had the third international consensus, where they have defined sepsis as a life-threatening organ dysfunction due to dysregulated host response to infection. And also they have come up with this QSOFA, which I will come to QSOFA in a bit. So that's the evolution of sort of sepsis, the evolution of sort of guidelines and management of sepsis. So as I said, the previous sepsis paradigm, they said if a patient has evidence of SIRS with the presence of an infection, they called it sepsis. So what is included in the systemic inflammatory response? A rise, a temperature, whether the patient was hyperthermic or hypothermic. White blood cell was accounted for that, a leukocytosis or a leukopenia, an abnormal heart rate, and an abnormal respiratory rate of more than 20 beats per minute. And as I said, sepsis does not spare like any age group. So in pediatrics also, they have for pediatrics, they have defined SIRS slightly different to us in adults. So a heart rate of more than 2 SDs above the normal age for children, and a respiratory rate again more than 2 SDs above the normal range for age in pediatric patients. So they said if two of the 4 criteria were present, so the patient was having systemic inflammatory response syndrome. But then with time, they realized that this SIRS does not always denote a dysregulated host response to infection. So it could be a physiological response as well. So let's consider a patient in the surgical ward maybe following a laparotomy. So you all have not given adequate pain relief following the laparotomy, the sympathetic system activation. Would the patient have a high heart rate? This is like a hypothetical situation. You all give adequate pain relief, I know. So if you all have not given adequate pain relief, the patient's sympathetic system is activated. Would they have a high heart rate? They would. Would they have a high respiratory rate? They would. So that is 2 out of the 4 criteria of SIRS. And if you do like a full blood count the next day morning, the post-op counts, would they have a high white cell count? Does that necessarily mean infection? Might not. And would they have a higher temperature? Because of this tissue in the body is mounting an immune response to counteract this the tissue injury. So they might fulfill all these 4 criteria, but does that necessarily indicate the patient is septic, the patient is having an infection? It might not. So there's a patient in the medical ward who's having a myocardial infarction, who's in chest pain. Would they have a high heart rate? Would they have a high respiratory rate? They might. So certain physiological conditions also, patient might fit into these septic, like SIRS criteria. So, so back in 2016, when they reconvened for the 3rd time, the Surviving Sepsis campaign, they were wondering whether there's a new SIRS, because SIRS could be present in certain physiological conditions as well. So then they came up with these 3 common elements, emerged as signs of organ failure, because we wanted to identify patients with sepsis who were at risk of developing organ dysfunction. So they have found this criteria: hypotension, a systolic blood pressure of less than 100, an altered mental status, and a tachypnea. In the obstetric patients, they modified it because they're anyways peripherally vasodilated, so they have systolic blood pressure of less than 90 in a pregnant patient, and they're anyways tachypnic for physiological reasons. So a respiratory rate of more than 22 was given to this criteria. So they introduced the QSOFA, quick sequential organ function assessment system, which was a scoring system that they used. And if out of the 3 criteria, 2 or more of the criteria were present, they said the patient is positive for having sepsis, and that was used for identification of sepsis from the 2016 guidelines. So the 2016 third consensus guidelines, there was a paradigm shift. So they defined sepsis if the patient had an infection, plus if they scored for 2 or more criteria from the QSOFA or the SOFA score. And they said septic shock if the patient had sepsis, and despite adequate fluid resuscitation, the patient showed evidence of hypoperfusion, evidenced by high lactate levels, more than 2 millimoles per liter. And if the patient was requiring vasopressor therapy despite adequate fluid resuscitation, if the patient required vasopressor therapy to maintain a MAP of more than 65, they defined this as septic shock. So this was the guideline which was available. From that guideline, you all must have heard of this golden hour of sepsis, or the hour 1 bundle. So what is a bundle in terms of medical practice? What is a bundle? A bundle is a group of interventions, if they are performed together, will yield a better outcome than if they were implemented alone. So, so this bundle principle was developed. So they gave us this hour 1 bundle, or the golden hour of sepsis, where which included this initial resuscitation. If you identify a patient who's having sepsis, this bundle was to be implemented. What was included in that bundle? You have to obtain blood cultures before administration of antibiotics. That was an important thing. You have to take cultures and give antibiotics, and that is the broad spectrum antibiotics, and you have to measure the lactate levels, and you have to begin rapid administration of crystalloids, 30 ml per kg crystalloid for hypotension or elevated lactate levels. So you measure the lactates. If the lactates are more than 2, that indicates inadequate tissue perfusion or an element of hypoperfusion. So they say start fluid resuscitation, and if during or after this fluid resuscitation, if the patient fails to achieve a MAP of more than 65, you have to start on vasopressor therapy. And if the initial lactates were high, you have to re-measure the lactate levels. That was the hour 1 bundle of sepsis from the guidelines back in 2016. And for ease of remembering, there's 3 things to take and 3 things to give. What are we going to take? We're going to take blood cultures, we're going to measure the lactates, we're going to catheterize this patient and monitor the urine output, the input and output. And what are the things that we're going to give? We're going to give oxygen, we're going to give fluids, and we're going to start antibiotics. And blood cultures, we do 2 sets of cultures, anaerobic and aerobic cultures. And if say in the ICU the patient has a central venous axis, we would do central and peripheral cultures as well. And also not necessarily like blood cultures, not only blood cultures. If there's like other sources of infection that you suspect, maybe a sputum culture, maybe a wound swab, maybe urine cultures, also can be included into the septic screen. So now that was the 2016 guidelines, and the Survival Sepsis Campaign, the international guidelines, they have reconvened back in 2021, and they have sort of looked back at their guidelines and done some changes to this management of sepsis. So from this slide onwards, we'll just go through these guidelines. I will be referring back to the our one bundle. Now they don't sort of like that update does not necessarily have like our one bundle, but we're doing the same thing. So I'll be like referring back to the our one bundle as well. So their recommendations, I will go through them one by one. So for hospitals, at the hospital level, they recommend the use of performance improvement programs for sepsis in hospitals. It's something like that we are doing today. We are all gathered here today to learn about sepsis, to improve our performance in treating patients. So in hospitals, they recommend performance improvement programs for sepsis, and also to educate the healthcare staff about sepsis screening and screening of high risk patients, and also implementation of standard procedures for management. So one ward can't be managing sepsis in one way, and the next ward cannot be managing sepsis in another way. So we have to standardize our management according to the existing guidelines. So another recommendation, so I was talking about screening tools for sepsis. Back in 2016, they came up with this QSOFA for screening of patients with sepsis. That enables physicians, these screening tools enable physicians to identify patients with suspected infection who have been treated outside public critical care units in ward setting who are likely to develop sepsis. Now, this new guideline recommends that QSOFA is not used as a single screening tool, because there had been certain researches done from this 2016 to 2021 period, and they have found that QSOFA is specific but not very sensitive. As we all know, a screening test should be very sensitive. It should, there could be like false positives, but it should not leave out any false negatives, because in a certain study they have found out that there had been some cases of sepsis, but QSOFA had only identified 24% of those patients as having sepsis. So it has left out about 3/4 of the whole like the group of patients who had sepsis. So it was specific but not very sensitive. So that's why the guideline committee recommends that it's not used as a single measure. So you can use your other scoring systems like the NEW score, the MU score, and SIRS criteria as well. If you think when you're doing your ward rounds, if you think this patient could be having sepsis, this patient doesn't look right, there could be the diagnosis of sepsis in this patient. So you can apply them to one of these screening tools and see whether they are triggering in these particular tools. So I want to sort of stress QSOFA should not be used as a single screening tool, but you have to use these other screening tools as well. You all can I'm sure you all have heard of these tools, the NEW score, the MU score. So it's a good tool to be implemented for screening of patients, not only for sepsis. If a patient is getting bad for like any other reason also, they will start triggering on these screening tools. And going back to the management, So they do recommend monitoring the lactate levels, as in the our one bundle I said you had to measure the lactate levels, but they say lactate levels is not sensitive or specific to rule in or rule out sepsis, because lactates could be elevated in other conditions as well. So say there's a patient who is in maybe heart failure in a medical ward, who is having hypoperfusion because primarily there's a problem with the pump. So that's not getting like peripheral, patient is not getting peripherally perfused. That patient's lactate also could be going up, but is that patient having sepsis? Necessarily not, because the lactates could go like it can increase in other situations as well. So lactate should not be used as a single test to diagnose or rule in or rule out sepsis, but in sepsis they still do recommend doing lactate levels and remeasuring lactate levels to guide your fluid resuscitation as well. So the initial resuscitation, so sepsis and septic shock. Sepsis can kill, so sepsis and septic shock are medical emergencies. So if you diagnose a patient with sepsis, you have to start treatment and resuscitation immediately. So they have, as in the other one bundle, for in the 2021 guidelines as well, they recommend if there is a patient with sepsis who has evidence of hypoperfusion, who has prolonged capillary refilling, who has increased lactate levels, they do recommend giving IV crystalloid 30 ml per kg to be given within the first 3 hours of resuscitation. So the house officers, if you think this patient is having sepsis and patient is showing evidence of hypoperfusion and hypotension, so you all have started your resuscitation. Are you just going to calculate 30 ml per kg, prescribe that, and probably see the patient in the evening again? No, you have to assess and reassess the patients. This is a medical emergency. You can't just prescribe the fluids and get lost. You all have to assess and reassess these patients. So those patients are can be critically ill. There is increased risk of mortality, morbidity. You have to go back to them, reassess them. What I mean is, like this 30 ml per kg, it's only a guidance. Sometimes patients might not need this 30 ml per kg. Sometimes it could be like a very small, like a very frail old Archie with sepsis. You're not going to bombard them with just 30 ml per kg of fluid just like that. You have to assess while you're resuscitating. And also some people might need more than 30 ml per kg. It's only a guideline. You have to always go by your clinical parameters, assess the patients every time you resuscitate. So the recommendation is to, if there's evidence of hypoperfusion, low blood pressures, you have to start fluid resuscitation with crystalloids and 30 ml per kg to be given within 3 hours from initial identification. And as I said, assessing them is very important. They suggest use of dynamic parameters over static parameters. What are dynamic and what are static parameters? A static parameter is a measurement that you take at one point of time. So you measure at the bedside, you measure the blood pressure, you just palpate the heart rate and take one measurement. So that is a static parameter. A dynamic parameter is like something like this. You give a fluid bolus and you like do a physiological and you see the physiological response to this intervention. So or like beat to beat assessment of a variable. So in the ICU we do assess dynamic parameters, but probably we don't have all the facilities in our ICU. But if we were monitoring the cardiac output, the stroke volume variation, the pulse pressure variation, those are dynamic variabilities. A simple thing that we can do is to see now you are resuscitating a patient. You are not sure whether this patient needs more fluids, whether this patient is going to be fluid responsive, but you are a bit sort of reluctant to give fluids to this patient as well. You are not sure whether you're going to overload the patient. So there's a simple way to check. You can check you can do a passive leg raise test. It's like giving a fluid bolus from his intravascular compartment. We are going to increase the venous return to see whether the patient is fluid responsive. So how do you do a passive leg raise test? The patient is Initially, the measurements are taken when the patient is semi-recumbent. The patient is lying at a 45 degrees angle, and then you lie down the patient and elevate the legs. So they say about like 300 ml of blood will be mobilized into the heart, which will increase the venous return. So if the patient is fluid responsive, the patient is going to have a heart rate response. The heart rate will reduce by 10%, and also the MAP also can increase by 10%. And but they recommend measuring dynamic parameters like the stroke volume variation or the pulse pressure variation from an arterial line. But in the ward setting, you can't do that. You can go by those simple parameters of heart rate and like a mean arterial pressure as well. So what I wanted to reiterate was that when you're resuscitating a patient, you have to assess and reassess the patient's clinical status and guide the resuscitation. It's not a blind process. You're very much involved when you're resuscitating a patient. You have to be at the bedside. I know the house officers, of course, they have a lot of work in the wards, but at a given time, there will be few patients that needs your 100% attention. A patient with sepsis in septic shock is one such patient. So, as I said previously, serum lactate levels to guide resuscitation in patients with elevated lactate levels. So, if the patient's initial lactate was high, so you can start resuscitating them, give them a few boluses and reassess their lactate levels. And that lactate also can be, apart from your clinical measurements, can be used to guide your resuscitation. And also, something that we can do in the ward setting for adults with septic shock, they recommend using the capillary refilling time to guide resuscitation as an adjunct to other measures of perfusion. So that's a very simple thing that you all can do, monitoring the capillary refilling time as a measure of tissue perfusion. So mean arterial pressure when we are resuscitating the patients in adults with septic shock, aim an initial map of more than 65 millimeters mercury is all right, is good enough to maintain vital organ perfusion. And so we are so escalation to ICU, whether you need to refer these patients to the ICU. So because we are a resource poor setting, we have only 3 ICU beds, so we might not be able to admit all the patients with sepsis or septic shock to our ICU. So you all will have to probably the recognition and resuscitation is very, very important at your level. But if you think a patient needs to come to the ICU, if you think a patient, the patient will be better, the patient needs some organ support, definitely he'll or she will have to come to us. So that if you are escalating to the ICU, it's best that the patient gets admitted within 6 hours from the initial diagnosis. That there will be a good outcome if that is done. So the next thing I would like to talk about would be the infection control or the antibiotics. So microbial cultures, as I said, should be sent before starting antimicrobial therapy. And if you are not sure whether this is sepsis, whether this is the diagnosis is sepsis, you have to continuously evaluate and search for other alternative diagnoses as well. But what I want to stress is we have to do the cultures before starting the antimicrobial therapy. So if there's definite diagnosis of a sepsis, you know that this patient has a focus of infection. So let's say the patient had a bowel perforation. Obviously, the patient is having sepsis, or the patient has a pneumonia. The patient obviously has sepsis. So irrespective of whether the patient is in shock or whether the patient is not in shock, we have to start antibiotics if the diagnosis of sepsis is definite. So sepsis, if it's possible, it might be sepsis, might be something else. But if there is shock, there's no harm in giving antibiotics within 1 hour of diagnosis of sepsis. But if you're not very sure, you can do like a rapid assessment of infectious versus non-infectious causes to find find the cause of this acute illness, because the patient might now be triggering on your new score or the mu score. That's why you're worried about the patient. So you can do a rapid assessment to see whether the patient has sepsis, and still if you If the concern of infection persists, there's no harm in giving antibiotics. If that sepsis, the concern of sepsis persists, you have to give antibiotics within 3 hours. And a little bit of about antibiotics. So if you think the patient is high risk for an MRSA organism to be involved, you have to start empirical antibiotics with MRSA coverage. For patients with high risk of multi-drug resistant organisms, maybe prolonged hospital stay, prolonged stay in the ICU, you have to start 2 antimicrobials with gram-negative coverage. And also for high-risk patients, you have to, for patients at high risk of fungal infections, you have to start antifungal therapy as well. And say in this previous instance, you are not very sure whether this is sepsis. There's like certain things for sepsis and certain things for some other thing. But the guidelines do not recommend using procalcitonin to start antibiotics because that's going to take long. You won't be able starting antibiotics within 3 hours if you do such investigation. You can just start the antibiotics and then see how things go. Examples of risk factors for fungal infection: if the patient has multiple locations of a candida colonization, if the patient is having neutropenic sepsis, if the patient is immunosuppressed on chemotherapeutic agents, maybe if the patient had a long ICU stay on central venous catheters or other intravascular devices. Those are certain things, certain instances where we should think about starting antifungal therapy as well. And another important thing is, so if you know there's a source which can be controlled, you have to start do that as well, because no matter what antibiotics we give and for how long we give, if we don't take the source out, sometimes the patient is not going to improve. So if there's abscesses, they need draining. If there's necrotic tissue, it needs excisions. And if the patient has like long CV line, long duration CV lines, other devices which can be removed should be removed. And if there's like if there's definite source control to be done, that should be done, like a bowel perforation, a bowel ischemia, which needs to be corrected. Those things should be the source control should be done in the meantime. And talking of antibiotics, de-escalation of antibiotics when they are not needed is also very important, rather than like prescribing an antibiotic maybe for 14 days, 21 days. Rather than doing that, daily assessment of infection status and decide on the duration of antibiotic therapy is important. If when we have the specific susceptibilities, narrowing down the spectrum is important, and discontinuing ones that are not needed is important, because long duration of antibiotic therapy can result in development of resistant organisms. In an instance where you're not sure of the infection status and whether the duration of therapy is unclear, in that instance probably procalcitonin can be important to decide, along with the clinical evaluation, for the discontinuation of antibiotics. A very, very important thing, the fluids. So fluid resuscitations, I said, crystalloids are the first line fluids that we are going to give, and they recommend balanced crystalloid solutions versus normal saline. What is the balanced crystalloid solution in the words? The HOs. What's the balanced crystalloid solution in the word? What is the balanced crystalloid solution? It's Ringer's lactate. Go to the ward today, take a bottle of normal saline, take a bottle of Ringer's lactate or Hartmann's and see. Hartmann's, it's more similar to plasma. It has sodium, it has potassium, it has chloride. Its pH is more similar to plasma versus normal saline. Normal saline is sodium and chloride. It's acidotic. If you give a lot of saline to a patient, the patient can develop a hyperchloremic metabolic acidosis. So they recommend RL or Ringer's lactate over normal saline for when you are using a lot of crystalloids to resuscitate patients. You can consider giving albumin as well. If the patient is requiring a lot of crystalloids, you can give some albumin as well. And but the guidelines do not recommend giving starches or gelatins in the resuscitative phase. And the next thing is, now you're giving fluids. After your fluids or during your fluids, the patient is not achieving a MAP of more than 65. We need to start them on vasopressors. The first line vasopressor is noradrenaline. It's a potent alpha-1 agonist which will constrict your blood vessels. So the primary problem with sepsis is vasodilatation, which reduced your SVR. What noradrenaline does is the opposite. It constricts your blood vessels and increase the SVR, so that the other side of the equation, the blood pressure will be increased. And the second line, they recommend vasopressin, which is again another vasoconstrictor. It's an endogenous hormone, but what we are giving vasopressin, if you are giving for sepsis, they recommend the use of 0.03 units per minute. And it acts on V1 receptors of the vessel wall and results in vasoconstriction. And if you want to add a third line, then it will be adrenaline. Adrenaline is a potent beta-1 agonist. Where are the beta-1 agonists in the body? Beta-1 agonist receptors, where are they? They are located in the heart. So in low doses, adrenaline works on the heart. It increases chronotropy and inotropy, increases heart rate, increases contractility, and increases cardiac output. So your blood pressure is a product of cardiac output into SVR. So it increases your cardiac output and thereby your blood pressure. So when the patient is on all these three, but if the patient has cardiac dysfunction, you can think of dobutamine as well. And can we start vasopressors in the ward? Yes, you can, because I said we can't accept all your septic patients, all the patients with septic shock into the ICU. We have only 3 beds. So you all can start vasopressors. Can it be started from a peripheral line? Yes, you can, but until central access is obtained. So if the patient is going to have an inotropic or a vasopressor requirement, you all have to convert your peripheral lines to central lines, and plus or minus transfer to ICU. And they do recommend starting monitoring invasive blood pressures as soon as it's practical or if the resources are available. So norepinephrine as first line, target MAP of more than 65. Consider invasive monitoring, consider initiating vasopressors peripherally, consider adding vasopressin, and consider adding dobutamine or switching to epinephrine. So if the patient is going to need this much of vasopressors and inotropes, probably the patient should come to us. So ventilation. So I said when we were discussing about the organ system being involved in sepsis, so the patients can these patients with sepsis can get hypoxemic respiratory failure. It could be due to the primary pathology. If the patient has a pneumonia, there's a primary problem in the lungs, and the patients can get hypoxic respiratory failure. And also non-pulmonary infections like a soft tissue infection or an infection somewhere else can result in ARDS, and the patients can go to hypoxic or type 1 respiratory failures. But like whatever the cause is, you all can start treating them in the wards. You all can start them on oxygen. So there's conventional strategies of nasal prongs or face mask with a reservoir or face mask with venturi. But the guidelines recommend maintaining, it doesn't recommend conservative oxygenation targets. So for ARDS, the ICU, the anesthetists know, like we go for like conventional oxygenation targets. We say if the saturation is 88 to 92, that's enough. But for sepsis in the initial resuscitative phase, we have to target a saturation more than that, preferably more than 95%. We don't recommend conservative oxygenation targets at this level. So if the patient cannot be maintaining adequate oxygenation, you all probably will have to think of escalation of your oxygen therapy. So what else can you do for escalation at the in the ward level? You can start on non-invasive ventilation, a CPAP mask, or high-flow nasal oxygen. The good things about a CPAP mask or non-invasive ventilation, it improves gas exchange, it reduces the work of breathing because the CPAP machine is supporting the patient's breathing, and also it assists in carbon dioxide washout. But you have to be mindful, there are certain like pitfalls as well. It can cause gastric insufflation because the patient doesn't have a definitive airway. If you are pushing air in, some of it can go into the stomach and there's a risk of aspiration. So I told you in sepsis, the patient can have altered mental status as well. So if you just put a CPAP mask and go away, sometimes the patient's GCS might be low and patient might be aspirating on the CPAP mask. So you have to be careful. You have to keep them under monitoring. And also there's a risk of facial skin being breaking down, and also patient discomfort. They might feel claustrophobic, they might not tolerate the pressure, they won't be able to communicate, they won't be able to eat. So there's a degree of patient discomfort as well. And the other is high flow nasal oxygen. I don't think you all have high flow nasal oxygen in the ward setting. Probably not. But that allows delivery of higher concentrations of oxygen, and it warms and humidifies the airway secretions, making it easier to clear the secretions, and it allows a modest positive airway pressure as well. But it's less effective to reduce the work of breathing, and it does not offer CO2 clearance, and it does not offer a higher PEEP. So if a patient is having type 2 respiratory failure, still for some degree or can manage in the wards, you can use NIV, you can use a BiPAP, which will allow some CO2 clearance. And if the patient is not responding, if you all think the patient needs to be escalated to ICU, probably patient needs intubation and escalation to the ICU. So this is a bit of management when they come to the ICU. So the guidelines recommend lung protective ventilation for sepsis-induced ARDS. We use low tidal volumes, around 6 ml per kg, aiming plateau pressures of less than 30 water centimeters, higher PEEPs. They have like PEEP and FiO2 charts where we go higher and higher on PEEPs, and traditional recruitment maneuvers like giving like an inspiratory hold, increasing the pressure in the airways so that these atelectatic lung units are opened up, and prone ventilation and intermittent neuromuscular blocking agents. And additional therapy. So the steroids in sepsis. So they recommend giving steroids in sepsis if they're requiring vasopressor support. Probably the patient should be started on hydrocortisone, 200 milligrams daily. Initially they thought it's best to give it as an infusion, but now they recommend the intermittent dosing, 50 milligrams 6 hourly. And restrictive versus liberal transfusion strategies. The HB target that they give is 7, but then you have to consider like the patient factors as well. And stress ulcer prophylaxis for patients who are at high risk, and venous thromboembolic prophylaxis unless contraindicated. So renal replacement therapy, when they come to the ICU, probably if they're having sepsis-induced AKI, they might need renal replacement. But they found no difference between intermittent HD versus CRRT. But there is like sort of added morbidity associated with going for renal replacement therapy as well. So they recommend not to commence renal replacement therapy just for rising creatinine levels, just for oliguria. But if you have absolute indications for dialysis like uremic complications, fluid overload, refractory hyperkalemias, refractory fluid overloads, refractory metabolic acidosis, probably the patient needs renal replacement therapy. And glycemic control is very important because increased glycemic variability like hyperglycemia, hypoglycemia, that also increases mortality in the critically ill. So you have to initiate insulin therapy and maintain your blood glucose levels between 140 to 180. And enteral nutrition, very important. Because that's the more physiological way of like feeding the patients. So they do recommend starting enteral feeding within 72 hours unless it's contraindicated. If the patient is relatively stable, starting on it, because it maintains gut perfusion, gut permeability, prevent translocation of gut bacteria into the vascular system and worsening sepsis. There's a lot of advantages of enteral nutrition. So starting enteral nutrition is also recommended in the guideline. So while we're treating for these patients, you have to think of long-term outcomes, and we have to decide on goals of care. Because in our parts of the world, we do not have this withdrawal of care, like setting ceilings of care. Probably we don't always do, but then that's very important, especially because we are like a poor, depending on the patient's condition, depending on the patient's prognosis, patient's comorbid levels. So you have to decide up to which extent are we going to sort of escalate the treatment. Are we going to escalate them to the ICU? Are they going to benefit from going to the ICU? Are we going to intubate these patients? So ceiling of care and setting goals of care and setting up like depending on the prognosis of patient is also important. And palliative care consultation they recommend, but usually in our setting palliative care is only for these cancer patients, but they do recommend these palliative care consultation. As I mentioned previously at the start of my lecture, even patients, if they recover from sepsis, they can go home with a lot of like life-changing side effects, life-changing alterations in their physiology. So they recommend peer support groups. And transitions of care is also important, especially if the patient was treated in the ICU, now going to the ward, transitioning of care. The level of care that we have given and the level of care that when they transit to a ward, that's also important. And educating the patients about sepsis, preventing another incidence of sepsis, that is also very important. And discharge planning, when we are discharging a patient who's had sepsis, who recovered from sepsis, it's important to mention what happened in the ICU stay, how many days were they ventilated, were they tracheostomized, whether they needed renal replacement therapy. Having a bit of like a discharge some notes in his discharge plan is important, especially if the patient goes to like say a different hospital after this admission, and what were his sepsis and related diagnoses, what treatment have we done, and now what are the common impairments they have. And post-discharge follow-up, they recommend physical, cognitive, and emotional problems could be there, and post-hospital rehabilitation. But with the patient loads that we have, I don't know whether we can implement all this, but at least the initial recognition part, the resuscitation part, and the management escalation, that we should be able to do for our patients. A bit on the future of sepsis management. Some therapies are being evaluated and may demonstrate benefits in the future. Biomarkers like procalcitonin, which is currently available to identify sepsis and guide therapies. And I said the changes, the pathophysiological changes occurs in the microcirculation of the body. So they are looking at assessment of the microcirculation to guide fluids and vasopressors. And immune stimulants, now currently we are giving general immune suppressants. I said if the patient is on a lot of inotropes, patient might need steroids, which are immunosuppressants, but they're looking at immune stimulants, whether there's a difference. And plasma therapies like cytosorb, high volume hemofiltration, to remove these harmful immune mediators. And also there's research going on for identification of several subtypes of sepsis, because all the patients with sepsis does not behave in the same way. They don't follow the same path. Some people may develop ARDS, some people may develop other complications like AKI. So there's like different subsets of sepsis. So they are looking at these subsets and whether the management should change for these different subtypes. So last but not least, maternal sepsis is very important. Is it difficult to recognize maternal sepsis? I would say, I'm sure Dr. Janaka agrees, it's difficult because their physiology, they have maternal patients, their physiology is changed during pregnancy because of the maternal hormones. They're anyways in a vasodilated state. So because of progesterone, estrogen, they're anyways vasodilated. What sepsis does? Vasodilate. So do they usually have like lower blood pressures? Yes. So do they have tachycardias? Yes. Their heart rate is is not like, I mean, a little higher than a normal, like a not pregnant patient. So also they are in a modified immune state. Their immunity is modified, so they have like a baby growing inside them. The body doesn't want to reject this baby, so their immunity is modified to a certain extent. So they're susceptible for infection. They're susceptible for genital tract infection. They're susceptible for like pneumonias, viral pneumonias, influenza. So they are a susceptible population. It's difficult to recognize sepsis in them. So you have to be very vigilant to catch sepsis in them. And we have to consider bacterial and non-infective conditions that may mimic sepsis. We have to consider the impact of antibiotics on pregnancy and breastfeeding. And yes, so maternal sepsis is also a very important area that we should consider, especially if we are caring for those patients. So stressing once again, sepsis kills. So it's really important to recognize early, resuscitate, and refer accordingly. That brings me to the end of my presentation. And if you all have any questions, I'll be happy to answer. Like as Dr. Rohit very correctly said, medical patients, especially I also have like during my short stay here, they have a, even like if we admit a patient from the medical ward for some other reason, most of them have elevated CKD levels. Most of them are unevaluated. So they can be coming with sort of their reserves, their cardiopulmonary reserves are not the same, and also they are like renal reserves are not the same. So when we resuscitate them, as he very correctly said, so fluid resuscitation will be a problem. Inserting like the decision or like how much to give, that's going to be a problem. Ideally speaking, they would need like a higher degree of monitoring, maybe an outline, maybe cardiac output monitoring to guide, if we are to guide the fluid resuscitation according to their physiological status. But understandably, we can't do, like even we don't have cardiac output monitoring even in the ICU. So you'll have to go by mainly the clinical parameters. But as I said, this passive leg raise test, if we can sort of implement in a ward setting, we are not giving any fluids from outside. So there's a patient who's compromised. He might be having like cardiac problems. If we give like a fluid bolus, the patient might go into like a, probably if it's too much, they might go into pulmonary edema. So if we do like a straight passive leg raise test, we are not giving fluid from outside, but we are using his intravascular volume to give a fluid bolus and to assess. And also I'm going to say, I've forgotten it now. So that could be challenging for your patients. Ideally, they should be in a monitored environment, but for our setting, we cannot get each and every one of them. So mostly you will have to rely on the clinical parameters and the lactates, and when we are giving fluids, rather than giving large boluses, we can give like a smaller bolus. Maybe not 500 for such a patient. We can give about 200, 250 and see the response, and then sort of assess the response and then give fluids. Yeah, so something like that. Shall we go for the quiz? Yes, sir. Yes, dopamine is especially in pediatrics because pediatrics they have it's like a different topics altogether. So I didn't touch much on pediatrics. Pediatric patients they can have warm shock and cold shock. Some children when they are in shock they are like in adult patients we say the peripheral vessels are dilated, so they are like peripherally vasodilated, very like it's like similar to like a warm shock in pediatrics. So they'll be vasodilated for them, or like they do recommend dopamine in pediatrics, especially in cold shock, because it has like a vasodilatory effect. It improves the renal perfusion. They do recommend in the adult population as well, but we don't much use dopamine much in adults. But in pediatrics, we do use dopamine, especially for cold shocks. Yes.
Thank you, madam, for that informative and comprehensive lecture. I'm sure it will make a positive impact on the patient management within our institution. So the next segment of our session is the quiz. So we expect active participation from you all. The questions will be displayed on the screen in front of you, and you'll be given 45 seconds to answer each question. So until the question is ready, I would like to take this opportunity to remind us about the sponsors today, Mr. Patiran and Mr. Chanaka from Hemas Sidus Pharmaceuticals. And I would also like to thank all the people who gathered here today and who contributed to make the event a success, including our team. And a special thank again to our speaker, Dr. Sumudu Senavirathne. So we'll be ready with the question in short time. participation. Now I call back our speaker to discuss the questionnaire with you all.
So we'll quickly go through the questions. So which of the following is true regarding sepsis? So this is the sepsis definition as given by the third the sepsis surviving sepsis campaign consensus. Sepsis is the life-threatening organ dysfunction due to its dysregulated host response to infection. And the last guidelines, the last updated in 2021, that was what we were discussing all this time. And regardless of the source of infection, sepsis can result in multi-organ dysfunction, and it's a major health issue worldwide. So all of the above are true. Which of the following is not included in the SIRS criteria? So heart rate, yes. Temperature, hypothermia, yes. Respiratory rate, more than 20, yes. So white cells, high leukocytosis, more than 12,000, or a leukopenia less than 4,000, and more than 10% of immature neutrophils in the white cell count. Those are all right. Abnormal mentation is in the QSOFA criteria, but not in SIRS. Which of the following is false about the pathophysiology? It causes peripheral vasodilatation resulting in low blood pressure. DIC is true. And organ hypoperfusion resulting in multi-organ dysfunction is true. Leaky capillaries resulting in edema, true. Sepsis-induced AKI, probably it's not necessarily due to pyelonephritis. It could be a primary infection in the kidney, but it's due to mainly because of hypoperfusion of the kidney that they get AKI. So which of the following is not a component of the initial management of sepsis? So this is sugar. It's an additional therapy to maintain normal glycemia. It's not in the other one bundle or the initial management. Which of the following statements is false regarding sepsis? So lactate levels can be elevated in other conditions. Any condition which causes hypoperfusion can elevate the lactate levels. And early recognition is important to start treatment to reduce the mortality and morbidity. And dynamic parameters, as I said, are superior to the measurement of static parameters, and serial lactate levels should be done to guide fluid resuscitation. And I sort of stressed that QSOFA should not be used as the sole screening test to identify sepsis. You have to use other screening tools, because this as a screening test is less sensitive. It's specific, but less sensitive. A screening test should be more sensitive than specific. A diagnostic test should be more specific than sensitive. So this is not good as a sole screening test, screening tool. Which of the following statements are true regarding fluid resuscitation? It should be commenced as soon as possible, and balanced crystalloids are preferred over chloride-rich solutions, and at least 30 mL per kg of fluid can be given, and albumin can be given as a resuscitative fluid in septic shock, but not starches, not gelatins, but albumin can be given. Which of the following is false regarding antimicrobial therapy? I don't know whether this is a good question, but antifungal therapy should be considered in patients on immunosuppressant therapy. Antibiotics should be administered within 1 hour. It's a part of the 1 hour bundle. And source control must be done as soon as feasible. And antibiotics should be de-escalated, as soon as clinically possible, to not like you start today and de-escalate the next day, but as soon as clinically possible. And for suspected multi-drug resistant organisms, you have to start 2 antibiotics with gram-negative coverage. Which of the following is true regarding vasoactive therapy? Norepinephrine is a potent alpha-1 agonist, and epinephrine in low doses, it does act by increasing the cardiac output from beta-1 adrenoceptor activity, and in higher doses, if you go to like 0.7, 0.8, 0.6 of adrenaline, its effects are dose dependent. Adrenaline effects are dose dependent. In low doses, it's a potent beta adrenoceptor activity, and in higher doses, it's again similar to like norepinephrine. It has alpha 1 activity, so then it will also cause vasoconstriction. Vasopressin must be commenced as soon as second line therapy when norepinephrine requirement is going up. They do recommend, if the norepinephrine requirement is going up more than 0.25 miles per kg per minute, to start on vasopressin. And vasoactive agents can be commenced via peripheral line in a ward setting until central access is established. All of the above are true. So which of the following is true regarding the management of sepsis? So patients require blood transfusion only if HB is less than 7, not necessarily. You have to decide from patient to patient. If the patient is having ischemic heart disease, maybe he might need a higher HB target. But generally they say 7, less than 7 transfuse. Hyperglycemia is known to increase mortality in critically ill patients. Yes. Steroid therapy, it's not initiated in everybody. If the patient is on vasopressors and the requirements are going up, you have to initiate. Enteral nutrition is best delayed until the patient is stable. No. As soon as clinically feasible, start. Presence of anuria is an absolute, it's not an absolute indication. Absolute indications are uremic complications like uremic pericarditis and refractory fluid overload, refractory metabolic acidosis, refractory hyperkalemia. Those are absolute indications because those things will sort of kill the patient if we don't control it. But anuria per se is not an absolute indication. So hypoglycemia, glycemic control, if it's going hypoglycemic variability is known to kill. And which of the following is true regarding maternal sepsis? So they are more susceptible for the development of infection, and it's not easy to identify sepsis in a maternal patient. It could be difficult because of the physiological changes. And only maternal mortality and morbidity is increased? No, it's 2 lives there. So invariably the life of the fetus is also at risk. So the impact on pregnancy as breastfeeding must be considered when we are prescribing antibiotics in pregnancy. Yes, so that's all. And thank you for listening and coming for this session today.
So it's time to find out who the winner is and proceed with the award ceremony. I would like to call upon Dr. Senavirathne again for handing over the present. Today's winner is Dr. Shenal Madagedara. I would also like to invite Dr. Saman Jayasinghe to hand over the token of appreciation for today's speaker, Dr. Sumudu Senavirathne. With that, we have reached to the end of today's program. So I would again like to thank all those who participate for the program, and also to the GMOA branch union, and for everyone who contributed to make this program a success. So before we call it a day, I would like to remind you about our next session. We are